Yes or no to this statement, end of life care. We can't afford to keep it to everybody, so we're going to have to ration it. Is that right or is that wrong? Well, since probably all of us at some point want to have our crack at it when it's our turn, but probably all of us in the meantime, we're going to have to pay for it for everybody else. And since there really are two serious sides to this argument, then let's make a debate of it. I'm John Donvan, a debate from Intelligence Squared US. We are in Chicago Ideas Week. It is a pleasure to be here. The motion that's on the table, ration end-of-life care. We have four superbly qualified debaters, 2 against 2, who will be arguing for and against this motion. Our debate goes in 3 rounds, and then the audience votes to choose a winner, and only one side wins. So let's have our preliminary vote. If you go to the keypads on your seat, we want to ask you to push number 1 if you agree with the motion, ration end-of-life care. If you would disagree with the motion, push number 2. And if you are undecided at this point, push number 3. So on to round 1, opening statements by each debater in turn. They will be 7 minutes each. And speaking first for the motion, Arthur Kellerman, the Paul O'Neill Alcoa Chair in Policy Analysis at the Rand Corporation. Prior to this, he was a professor of emergency medicine. Ladies and gentlemen, Arthur Kellerman.
The goal of emergency medicine is always to save lives. But you would be surprised how often we have to make decisions in consultation with patients or their families about whether or not initiating heroic measures is in fact the right thing to do and what the patient really wants. It happens when a critically ill patient is rushed to the ER in the very last stages of a terminal illness. Now, from a medical or a business perspective, the easiest thing to do by far is just full court press. Start resuscitation, intubate the patient, roll out the breathing machine, put in IV lines. But, you know, it doesn't always accomplish what we want. And rather than prolonging life, it simply prolongs the process of dying. That's why when Intelligence Squared called me and asked if I would do this debate tonight, my answer was an immediate yes. Not only because of what the patient goes through, but what their family goes through too. Now, to clarify what we're debating tonight, I think it's important for us to define just what we mean. What kind of end-of-life care are we talking about? Medical and surgical treatments that do not achieve a reasonable goal of medicine should not be used. Limiting this type of care is not rationing, it's good medicine. Many treatments are used to achieve goals that patients did not want or were not proportionate to the burdens that the treatment imposed because there was either ineffective communication about the disease prognosis, there was a failure to achieve adequate, informed patient consent, or there was no advanced care planning. Avoiding these treatments is not rationing, it's simply rectifying poor quality care. Now, some treatments are desired, but they're extremely costly and have a very low chance of success. Declining to pay for such treatments is what most people would consider rationing, and my teammate, Professor Singer, will have more to say about that in a minute. But finally, there is one type of end-of-life care that is not used often enough. It's relatively inexpensive, it's highly valued by patients, and it's effective. It's palliative care. Palliative care is specialized care that's focused on relieving pain, relieving the burden of symptoms, helping a patient to be as comfortable and as functional as they can be as they approach the last days of their lives. Now, 2 years ago, a group of cancer specialists published an amazing study in the New England Journal of Medicine. They took a group of patients with a very serious type of lung cancer, and they randomly assigned it to 2 treatment groups. One treatment group got palliative care and standard cancer treatment. The other group got very aggressive advanced cancer care, and they followed the 2 groups. The palliative care group not only had a better quality of life and less depression prior to their death, they lived longer than the group that got aggressive treatment. Do patients in the last stages of terminal illness have an unqualified right to extremely costly treatments of uncertain value for as long as they want? Because if the answer is yes, the rest of us have to be prepared to pay the price. Despite remarkable progress in medical science, the global death rate is still 100%. So the question is not whether we're going to live or die. The question is where and how we'll die and who will be with us when we do. Most of us don't want to die in an intensive care unit, strapped to a bed under fluorescent lights, separated from our loved ones. As a physician, my goals are simple: to save as many lives as I can, to ease pain and suffering when I cannot, and always, always treat my patients with compassion and respect. That's why at the end of this evening, I urge you to vote for the proposition. Thank you.
Thank you, Arthur Kellerman. Our motion is ration end-of-life care, and our next speaker will be speaking against the motion, Sally Pipes. She is President and Chief Executive Officer of the Pacific Research Institute. She also writes a weekly health column for Forbes.com and is the author of The Pipes Plan, the top 10 ways to dismantle and replace Obamacare. Ladies and gentlemen, Sally Pipes.
Thank you, John. And I'm against the proposition that we should ration end-of-life care. My mother was Canadian and a senior. In July of '05, she felt she had colon cancer. Her primary care doctor said she did not because he did an X-ray and no cancer showed up. Well, we all know that colon cancer is not detected by an X-ray, but by a colonoscopy. But she could not get one in Canada because of her age and the fact that a waiting list for people under 65 with colon cancer symptoms was over 6 months. So by late November, my mother was hemorrhaging and had lost 35 pounds. She knew she was ill, and she went to the hospital in an ambulance and went to the emergency room, spent 2 days in the transit lounge. Then she did get her colonoscopy. But sadly, she passed away 2 weeks later from metastasized colon cancer. This is the outcome when government bureaucrats set the rules for who is going to get care and when. Rationing care at the end of life may be a sound solution in the abstract, but when it comes to your mother, your father, or your child who has a terminal illness, it is wrong for social engineers and government bureaucrats to make these life decisions for you. So how will the Affordable Care Act ration care for our seniors, and in particular, those in need of health care? In 3 ways: the Independent Payment Advisory Board, accountable care organizations, and the Patient-Centered Outcomes Research Institute. IPAB will be a panel of 15 unelected members appointed by the President and approved by the Senate, whose job it is to cut Medicare spending. It will go into effect when federal spending by doctors and hospitals on Medicare exceeds the average consumer price index growth rate between 2014 and 2018. After that, costs will be tied to GDP growth plus 1%. The accountable care organizations is second. They are a delivery model for doctors and hospitals and to give them financial incentives to provide good quality, coordinated care to Medicare beneficiaries while keeping costs down. They would benefit by sharing in savings with the government if costs are lower than projected for treating Medicare patients. If higher, ACOs would have to pay back funds to the government. It is my belief that doctors and hospitals will ration or deny care to seniors if they feel that their costs would exceed the ceiling. ACOs are a giant HMO. Third is the Patient-Centered Outcomes Research Institute. It is similar to NICE in the UK, a government agency that determines which treatments are cost-effective as compared to medically effective. And while it is true that 5% or 2.5 million seniors in their last year of life consume 25% of Medicare spending, it is still my belief it is not the government's place to limit costs by sacrificing lives. End-of-life decisions should be made by doctors and families not bureaucrats such as those on IPAB and PCORI. They will ration the care our seniors receive, and I believe that is ethically and morally wrong. In my view, people have every right to live as long as they can. Therefore, I urge you to vote against the proposition. Thank you.
Thank you, Sally Pipes. And a reminder of where we are. We are halfway through the opening round of this Intelligence Squared U.S. debate. I'm John Donvan. We have 4 debaters, 2 teams of 2, fighting it out over this motion, ration end of life care. You have heard the first 2 opening statements, and now on to the third. Debating for the motion, ration end of life care, the Ira W. DeCamp Professor of Bioethics at Princeton University. He's been called the most influential living philosopher by The New Yorker and is the author of a number of books, including The Life You Can Save and Animal Liberation. Ladies and gentlemen, Peter Singer.
Thank you very much. It's the position of our side that we are already rationing health care. So in a sense, we cannot really debate whether we should do so. The question that we can discuss is whether we should be open and explicit about what we're doing, and therefore try to do it in the best, most thought-out way possible, which essentially means do it in the way that gets the best value for the health dollars that we're spending now, or whether we should continue to do it in a way that we don't bring out in the open, that we cover up, that we don't really dare to discuss. Now, it's clear that we are not spending our health dollars effectively in this country at present. We spend about between 17 to 18% of everything we have, of our gross national product, on health care. That's about 50% more than other comparable countries, the other industrialized countries that we compare ourselves with. There is no evidence that we get any better outcomes for the extra 50% that we're spending, the extra 7 or 8% of GDP that we're spending, than those other countries. I think that there's a general feeling that this healthcare system is not delivering what we want. But as I said, it is rationing. It rations in many ways. For example, we have about 44 million people, Americans now, who are not insured at all. That number will drop significantly when Obamacare comes into effect, but it will not, unfortunately, drop to 0. Now, not being insured means that you are more likely to die if you have a serious illness or accident. In fact, Joseph Doyle, a MIT scientist, looked at people who were brought into emergency care as a result of road accidents, seriously injured, and found that those who were uninsured died at a higher rate, even when adjusting for other variables, than those who had insurance. And when he calculated how much it would have cost to save these people's lives, it would have been about $280,000. Reasonable amount of money, but that was how much more was spent on saving the lives of the others. But given that these are mostly fairly young people, in terms of how much it would have cost to extend their life for 1 year, it would be about $5,500. These people's lives were lost because we were not prepared to spend $5,500 for each year of life that we could have saved. Compare that with the amount that those much criticized bodies, Sally Pipes mentioned NICE, the National Institute for Clinical Excellence in the United Kingdom, what they say is too much to spend. Currently, NICE's figure is around $49,000. In other words, almost 10 times, 9 times as much as would have saved the lives of these young accident victims. And of course, we ration in a lot of other ways as well, because some people can't afford co-payments, we have long waiting times, we don't pay doctors enough for Medicare, and so they don't take Medicare patients, so they don't take so many Medicare patients. So we are losing lives, and we are losing lives that we could save quite cheaply. We cannot increase healthcare spending indefinitely and also spend more on the elderly and spend more on the environment, on education, on all of the other important things that we need. So, like it or not, we are rationing healthcare. We are arguing that indeed we should, that's obvious, but that we should be more explicit about it because we want to get the best results we can. We want to save the most number of lives that we can, and the way to do that is to be explicit and vote yes for this motion. We should be rationing healthcare. Thank you.
Thank you, Peter Singer. Our motion is ration end-of-life care, and our final debater will be speaking against this motion. That's Ken Connor. Ken is chairman and founder of the Center for a Just Society. He is a successful trial lawyer. He represented Governor Jeb Bush in the long-running Terry Schiavo case, and for several years served as president of the Family Research Council. Ladies and gentlemen, Ken Connor.
Good evening, ladies and gentlemen. Sally Pipe's mother's situation is Exhibit A to why Americans don't want the government to wind up rationing health care in this country. By contrast, my mom suffered from advanced colon cancer late in life at an older age than Sally's mom. She received aggressive treatment, both surgery and chemotherapy, made a full recovery, and went on to live more than a decade of a good and healthy life until she finally died at 90 at home in good health in her own bed. Which system would you prefer? Ladies and gentlemen, I'd like to make 3 points, if I may, about why government should not be in the business of rationing health care. First of all, that health care decisions should be made at the end of life, just as at any other point in life, at the bedside by the people involved and who are affected, not by bureaucrats at a remote location. The decisions about what kind of care ought to be administered at any given time to any given patient should take into account the needs of the patient. In other words, health care should be both individualized and particularized to the needs of the given patient. There's simply no way that a government functionary practicing assembly line medicine in Washington can make those kinds of decisions. Health care requires the fine edge of a scalpel, not the blunt end of an axe. Now, no one is suggesting for a moment that we should not be good stewards of scarce health care resources. We absolutely should be. But rationing is not what we need. It's rational care. We ought to be asking ourselves, is the procedure under consideration necessary for the patient? Is it clinically appropriate? Is the cost reasonable compared to similar services? These are questions that ought to be answered by people with their feet on the ground in the hospital in real time, by hospital utilization committees, and not by people who are remote from the bedside. Now, folks, make no mistake about it. Government rationing represents the first step down the road to the utilitarian philosophy of former Colorado Governor Richard Lamb, who said, "The elderly have a duty to die and get out of the way." This philosophy sees the elderly and the handicapped as resource hogs whose useful life is over and who now cost more to maintain than they produce. They reject the sanctity of life ethic that has long prevailed in this country and that maintains that every human life is precious and ought to be respected and protected under the law. That view affirms equal protection for all, for the whole and the handicapped, for the very young, and for the very old. Instead, the quality of life advocates maintain that we should use quality of life calculus and functional capacity studies in deciding who lives and who dies. Folks, I would suggest to you that there are many places that we can look to find the savings that we need to provide appropriate care for the sick and for the dying. For heaven's sakes, we spent $4 trillion on the Wall Street bailout to rescue businesses that engaged in profligate spending practices. Surely we can spend the money required to render appropriate health care to the sick and the dying. Ladies and gentlemen, I urge you to vote against the proposition, because by the time you reach the end of your life, you'll be glad you did. Thank you.
Thank you, Ken Connor. And that concludes round one of this Intelligence Squared U.S. debate. Now we move on to round two. Round two is where the debaters address each other directly and also answer questions from me and from you in the audience. We have two teams of two. Arthur Kellerman and Peter Singer are arguing for the motion, ration end-of-life care, and we have heard them say basically that we already are rationing, that health care is rationed right now by the ability to pay for it by the individual, and that it is time to be explicit, to ration in a different way, to step up and admit that's what we're doing and figure out a system for doing it. They say that you need to figure out how much saving a life produces in terms of results. You have to compare that to how the resources could be used elsewhere. The team arguing against the motion, Sally Pipes and Ken Connor, argue that rationing end-of-life care is the wrong way to balance the budget. They say that it would be falling to government bureaucrats to make intensely personal decisions, that cost should not be the driver of a decision regarding the end of life, and that they depict a future where basically the elderly will be thrown overboard. Now, I noticed that the two sides do agree that cost cutting needs to happen, that costs are out of control. They do agree that ideally these decisions will be made at the bedside by doctors and their families. The question is, who ends up controlling where the money comes from? And I want to put to the side arguing in support of rationing end-of-life care, and particularly to Peter Singer, this basic question: is there a way actually to arrive at a dollar value for what a few more months of life would be worth to an elderly person versus what it would be worth to a younger person? And does that explain whether, does that price carry over to whether a procedure is worth pursuing or not? Can you put a dollar number on these things?
It's very difficult to agree on dollar numbers. I mean, health care economists try to do it because really what they're doing is they're comparing what you get for your money if you spend it on one thing, let's say saving young people's lives, and what you get for your dollar if you spend it on something else, perhaps Avastin, say, for cancer, where it can only extend life by 2 or 3 months at significant expense. And I think what they can clearly say is we get better value in some cases rather than others. We extend life for longer for the same amount, or we extend life for an equal amount for less money.
And you said in your opening remarks that younger lives are less expensive, generally speaking, to save than older lives, with the outcome of a longer life lived because the person's younger rather than older. Am I reading you correctly?
Well, I think most of us would agree that it's a greater tragedy if a 20-year-old dies because they were in an accident and didn't have health insurance than if an 85-year-old dies. I think we would feel that people have lived most of their life, achieved most of what they were going to achieve when they die in their 80s, let's say. It's still sad, of course. I know it's sad, but it's a greater tragedy. It's worth spending more to prevent if we can save the life of somebody who still has most of their life in front of them and still has a lot of things that they can achieve.
All right, so I'd like you to respond to that in light of your saying in your opening remarks that each of us has the right to live as long as we can. Does age come into it? Do the younger have more of a right to live as long as they can than the older?
No, I believe we all have the right to live as long as we can. Only when someone has died can we actually measure the cost of what the cost of keeping that person alive is.
All right, and Ken Connor, your partner.
John, I'd like to weigh in against that kind of calculus. In America, we hold to the proposition that all men are created equal. Equal protection of the law is a hallmark of American justice. And I would suggest to you that any point of view that says that a person's dignity diminishes with age, or that somehow their personhood erodes as they get older, is a point of view really that is a bankrupt point of view. And inevitably, that point of view will endanger everyone who reaches old age, or anyone who should suffer from the slings and arrows of misfortune and wind up suffering a serious illness or injury.
Let's take the specific part of your question that relates most closely to this motion to Peter. And if you were the rationer in chief,
do you have a very likely scenario?
No, it's unlikely to happen for any of us. But do you have a system, or do you have the outlines of a system? Do you have a philosophy about how this should be approached?
I would try to look at the number of years that we can expect to extend people's lives for a given number of dollars. I would also try to look at the quality of life as well. Now, that certainly may be affected by dementia, but in addition, especially with older people, I would hope that they would be encouraged to state their own wishes as to what should happen to them if they become demented.
But Peter,
Or if other things happen to
assuming you're correct that you're not going to get the job, what body do you see making the decisions?
So I think actually, although it's much criticised, I think that the UK model of setting up, they have a National Institute for Clinical Excellence. Sally referred to it by its acronym, NICE. Not everybody thinks it's nice. But what they do is they try to cost the various treatments that are out there, and they try to get expert data on how long those treatments extend life in a variety of different conditions. And they make recommendations, they're not binding, but they make recommendations to the local area health authorities throughout the United Kingdom to suggest that this treatment does give good value for money, you should be providing it, but perhaps this treatment for this specific condition is above the bar that we think reasonable, and you may consider not providing that. And the health authorities then reach those decisions.
And how often, if you happen to know, how often is there a recommendation not to use a particular intervention or treatment? Is it uncommon or is it pretty common?
It's relatively common that there are some treatments for some specific conditions that are considered too expensive to provide. And I think that that's going to be inevitable because medical technology really has no limits to how much it can cost.
Let's hear from your opponent, Sally Pipes.
Right. So you are a proponent of NICE, which I think the Patient-Centered Outcomes Research Institute is patterned after. But if you read the British press about people, the quality-adjusted value of life, if you're, say, 68 years old and the actuaries within the National Health Service bureaucracy say your life is worth $49,000. You may be have been diagnosed with a severe cancer, macular degeneration, but if the drugs to take care of this are costing more than $49,000, you are denied care in the United Kingdom.
We do have smaller versions of single-payer systems. We have Medicare, we have the Veterans Administration. They have to make decisions. They have to cut costs. Do they need to have a system of rationing in the system that exists now, as opposed to what you're proposing as a solution, which just is not the world that we're in today?
Well, I think it's important to understand as a practical matter the truth of the notion that he who pays the piper gets to call the tune. And so as a practical matter, whoever's making those payments in large measure is going to call the shots. What we advocate, though, in contrast to a central, bureaucratized, central planning decision-making process, is that we have consumer-driven decision-making, informed by medical advice, mediated by markets. We believe that that system is a better system than the government system, the Wall Street bailout. Now, look, folks, plain and simple, there's an economic concept that our physician friend may not be aware of. It's called opportunity cost. And your proposition assumes the fallacy of only two alternatives. Either we recoup the money from the sick and dying or we don't. But my point is there are other ways to recoup the money from other areas where we are wasting money, and it's much easier to balance budgets on the back of the sick and dying than to wrest it out of the hands of the special interests in Washington.
Arthur Kellerman.
I'm real glad I got a chance to talk.
My apologies.
Let's talk for just a moment about Exhibit A. Sally, as a doctor, I got to tell you, I've heard that story before, and
Remind people just tuning in to what Sally said was Exhibit A.
The story earlier about your mother not getting the colonoscopy she needed. And
In Canada.
I feel badly about what happened. But I have to tell you, I don't think a government bureaucrat was the one who made the mistake. I think you got a bad doc. And the fact of the matter is, I know this may come as a shock, sometimes Canadians screw up. If they didn't, we'd never win the Stanley Cup.
Right. Well, you have to agree,
and
Canadians
Mr.
are
Connor.
really nice people.
Yeah,
And they're
Mr.
very
Connor.
patient, not like impatient Americans, which I am
Mr.
now
Connor,
one of.
I'm with you, brother, on the market incentives. So let me suggest a market-based solution to what we're talking about. I think there's a big difference between deciding what we as a society can afford to commit folks to get, whether it's in an ICU at the end of the life or whether it's at 25 years old when you're trying to get your first job and starting a family. And let's commit to that level of financial protection and coverage that we all kind of want to buy into. If beyond that, whatever that is, whatever we as a country decide we are prepared to shoulder, you can buy it. Sally, you could buy it. If you want a Avastin and it's worth $100,000 a year to pay for it out of your pocket, and you want to use your children's inheritance, go for it. It's okay with me, but I've got a problem with you using our inheritance to buy your Avastin if we don't have the evidence that it makes a difference.
I want to shape this back to what we're talking about as a trade-off of what you get for what you pay, and are you willing to pay it, and is it wrong to deny that payment? And Ken Connor, you actually did put your finger on it when you said that, he who's paying the cost gets to call the tunes on this. And right now we are in a world where Medicare is taking care of an awful lot of people, and it's very expensive. We know a crisis is coming.
Well, I think you're talking about fundamental fairness here. And let's think of it in these terms. How fair is it when you pay into something all your life, and you get to the end of your life when you really need it, and you've been told that you're paying in to receive health care, and you get down to the point when you really need it and the government says, sorry, you're going to cost us too much. Isn't there a fundamental fairness issue in that regard? No, we're going to take the money that you paid in over time, over all these years, and we're going to give it to younger people because they don't need as much of it as you do. Isn't that why we paid into it all of our lives? And isn't that part of fundamental fairness is getting what you pay for?
Okay, and the question I want to put to this side out of this is that he's actually portraying what sounds like a very ugly situation. You're old, you've got 2 years left, we got a limited amount of money, that group of kids over there, they've got all their lives in front of you. Sorry, Charlie, you're off the boat. It does sound ugly, nasty, and very hard to take, and I want you to take on that side of the argument.
Well, the only problem is that's not how it works, and that's not what we're talking about.
Well, it is what we're talking about.
I mean, we're talking about, again.
No, it is, but Art, it may not be how it works.
Yeah.
You can correct me on that, but we are talking about having to make these hard choices and saying no to some people.
Yeah, what we're saying is we want to give everybody good, decent, high-quality, evidence-based medicine and care, including and especially palliative care at the end of life. But if you want a super expensive drug or an unorthodox treatment that costs a freaking fortune, and it is way beyond what we think as a society, private insurance's actuaries or the government's actuaries or the Institute of Medicine says is reasonable, then we should not, as a society, be obliged to go along for the ride. You should be able to pay for that out of pocket or in any other way you want to do it. That's a fundamental difference in saying, no, you can't have it at all. And let me remind you, we talked about wasteful spending earlier.
But wasn't Peter describing a situation in the UK where they do look at specific treatment and they say, if you want to stay in the national health, you can't have it at all?
Well, I'm sorry, I thought we were in the United States.
No,
so
but Peter
Yeah.
Peter used the United Kingdom system as an example, so I think it's on the table.
Yeah, but let me just mention something that I think I got to put on the table because I don't know how much time we're going to have. A cynical colleague of mine once said, Americans don't mind throwing people overboard, they just don't like to hear the splash. And there are an awful lot of people that are getting thrown overboard every day in this country that we're not debating about tonight.
All right,
We
but
keep
that's-
this
but
debate-
that is
no,
not the debate tonight.
It's really important. Sally told a story, I'll just briefly tell a story. Early in my career, I saw a woman in her 30s, a mother of 3, who rolled in the door with a hemorrhagic stroke. Her blood vessel burst in her brain. She was neurologically devastated. We intubated her. We did everything that Sally and Kib would want. We gave her a full court, all-out, best we could humanly do, and we could not save her life. I went to break the news to her sisters, and they told me that 3 weeks earlier she'd lost her job, lost her coverage, could not afford her 3 blood pressure medicines, and was forced to choose between groceries for her kids or medicine for herself. She chose her kids, like any mother in this audience would choose, and she paid for it with her life. Her life had value. She died. We spent more money in the last 3 hours of a completely futile effort to save her life than could have kept her in blood pressure medicine her whole life, raised her kids, paid her taxes, contributed to our country. Those people matter too.
I want to go to questions from the audience, but I just want to finish this up. Should she have been denied that service since it didn't make sense economically?
What?
the extraordinary effort to save
No,
her life.
because early on you don't know how things are going to turn out. But at some point you say, and again, what we said at our opening conversations here is the most important discussion to have is between a physician and the patient with an honest sharing of information, not get pulled in to an industrial complex of modern medicine. Just remember, we were talking about the Affordable Care Act or Obamacare earlier. One of the first provisions that got knocked out of it was one that would have given doctors a little money every 6 months to encourage them to have a conversation with their patient. And you know what we called it, folks? We called it a death panel. What the hell was that about?
Let me ask you this, Doctor.
I don't know 10 doctors in America that thought that was a good idea to knock that out.
I'm going to let Ken respond. I
let
think
me-
you're going with a question, so
Yeah.
make it a question.
Let me
and
ask
then
you this,
I'm
Dr.
gonna go to
Kellerman,
you
if I
first.
may. You've made the point, and you've written about it, and it's a good point, that some 15,000 people die estimated every year because of the lack of insurance coverage.
Easy.
The Institute of Medicine estimates that 100,000 people die a year from medical malpractice. Are you willing to be as aggressive about reforming medical malpractice and ensuring that physicians meet the standard of care for those 100,000 as you are to argue for the thousands who don't survive because of the lack of insurance?
Absolutely.
Good.
Sign me up.
Good.
And you know
All
what?
right.
And while we're at it, let's cut out the $750 billion a year that the Institute of Medicine says our healthcare system, the one I work in, is wasting due to inefficiency, wasteful management, missed opportunities prevention, and fraud. $750 billion,
Questions from
folks.
the
We can
audience?
do a lot of good with that money.
If you'll wait a second, Mike will come to you, and you can stand up if you wouldn't mind telling us your name. And just wait for the mic. Thanks.
Yes, hi. My name is Patrick Batchelor. The trick part of the question, I think, tonight is, do we really know when end of life is until we get there?
There are many, many cases. I mean, I never try to predict for an individual patient, but what I do tell a patient is, this is the situation, this is what could happen, what do you think is the right thing to do? And I respect their wishes and I respect the family's wishes, but you've got to give them honest information. You've got to give people a sense of odds. Everybody is 1 or 0 as an individual, but the odds and the outcome and the prognosis really matter, and people need to understand what they're signing up for.
My name's Julie Goldstein. I'm a palliative care physician and educator. And my question is, do you think that if we were to address the waste head-on by education, et cetera, that we might save enough money that we wouldn't even need to we wouldn't have the need to ration?
I'm glad you brought that up. I really believe that if we focused on getting rid of bad medicine and eliminating the kind of errors and communication problems that I discussed, and reinforced and sustained palliative care, that takes care of 90% of this issue.
Well, listen, I affirm, Doctor, the premises of your question, which is, if we can eliminate the waste, fraud, and the abuse, doesn't that obviate the need for rationing? And that was the point I tried to make in my opening statement, is that the alternative is not simply ration or not. The question is whether or not we're going to waste continue to waste money and then promote the need for rationing because of it. Now, the Institute of Medicine reports, for instance, that we spend $75 billion a year because of healthcare fraud, $190 billion in excess administrative costs, inefficiently delivered services, $130 billion a year. Now, my point is this. It's easier to argue for balancing the budget on the backs of the old people who aren't voting and who don't have lobbyists and who don't have PACs than it is to try to wrest the money away from the people who are perpetuating the fraud or rendering these services inefficiently. Let's do what we need to do to reform wasteful spending and not force ourselves into a position where we think we have to ration health care at the expense of the elderly.
You just lost me there, Ken, because I thought you said earlier that what we want to do is get government out of the business and let doctors do whatever the heck they want.
No,
But
I
you just
think
told us
when-
we were
I
wasting
think when
$750 billion, so I'm
when
trying to get
when
these
healthcare
two.
providers perpetrate fraud, government has a legitimate interest in stopping that fraud. That's a perfectly appropriate role for government.
But it isn't just fraud.
Peter Singer.
I mean, the problem is that the financial incentives in the market system that the opposition are defending all the way provide incentives to do more. Here's an example. The national rate of caesarean sections is 34% of births. There's an outfit called Intermountain in Utah Healthcare that has a caesarean rate of 20%. It saved $50 million by doing fewer caesarean sections, but it cost it money. It lost money by doing fewer caesarean sections. By saving the system $50 million, it suffered a financial hit itself because the financial incentives are to do more and you get paid more and you can build up your financial base, expand staff, etc. So this is the problem with allowing this to be done through the free market. We need something that puts a lid on not just fraud, but also the incentives to do more medical treatments.
Does everybody, regardless of their status and stature in life, deserve exactly the same care when the government is what is going to pay for that care?
What a great question. Ken Connor.
Well, in America, we've historically said that we're entitled to equal protection under the law. And so the government arguably has an obligation to treat everyone the same. Now, in the marketplace, it doesn't always work that way. We talk about equal opportunity, not equal outcomes. And so that's what I like about the marketplace, is that decisions can be made in the marketplace. Look, the notion that government is more qualified to make decisions and to allocate resources than markets, I think, is a foolish notion. The history of the world suggests otherwise. The Soviet Union imploded on itself because its central managers were not efficient. But in the final analysis, I think we need to understand that the Constitution is a hedge against government. It's not a hedge against individuals. It's not a hedge against markets. But the Constitution limits the powers of government. So if government is going to assume certain responsibilities, it's bound by the chains of the Constitution, and I think we want it that way.
But
Well, can I answer,
but,
just make a quick
to
point?
go to the question,
Yeah.
though, your question was, does everybody deserve the same level of care,
Yeah,
regardless of who they are? And are you talking about extraordinary measures at the end of life care, which may need to be rationed because of scarcity of resources?
That's what this debate's about,
Yeah.
I believe.
All right, so your question, but I think Sally Pipes said in her opening statements, each of us should have the right to live as long as we can.
Right. And if you're, these people are 72, you said, or 71, they're obviously on Medicare because they're seniors. And I think I'd like to ask Art, when someone turns up at an emergency room, they're on Medicare, do you ask, are you an ex-prisoner or are you unemployed? I think that there's a responsibility in the emergency room to treat these people. And I know, most doctors I know who are ER doctors have no idea whether the person is wealthy or poor or whatever. So I think that under Medicare they should be treated by Art or whomever. No.
Yeah.
So for scarce resources, I view that there's kind of two types. One is hospitals and doctors, and the other is government capital and government money to spend. And so I view them as kind of differently when I think of rationing end-of-life care. And so I've kind of first, in terms of from this side, I believe I've kind of heard that you're in favor of rationing government spending while not rationing hospitals and doctors for those who want to pay for it. And I'm kind of, so first I want to know, is that kind of correct? And then also for this side, do you view that, why shouldn't somebody be responsible to, save up their money or pay for private insurance and so that they can pay for that end-of-life care while the government can ration the government spending but not ration the doctors and the hospitals?
I want to take your question as an opportunity to bring up another key point, which we spent a lot of time tonight talking about economics, and we spent a little time talking about the uninsured and the underinsured. But there's another group that really suffers under the current system, and those are the folks who are lining the hallways and in trauma bays and ERs waiting for the ICU bed that they can't get into and are there for 2 or 3 days. The ambulances are diverted from a trauma center to a non-trauma center because all the beds are full. We are not a country of unlimited money or of unlimited critical care capacity. And so my perspective, and I think my colleagues' perspective, is given that we live in a finite world, we want to do the most good for the most people possible, and that should be our fundamental mission. You can call that rationing, you can call it rational use of resources, but every life has worth. And the fact that somebody got there first shouldn't be ultimately the prevailing decision. We've got to maximize the benefit and the value and the good to society.
What's the system then, Art? Then what's the system then?
The system is, again, you have to make decisions, you work with families, you have to figure out where can you give people the best chance.
Does Medicare get to set up a panel to say we're going to provide this particular procedure or not because evidence-based medicine suggests it's not cost-effective? Does Medicare get to say we're not going to do that?
I think Medicare gets to say we're not going to pay for it.
That's what I mean.
Yeah, I think if you say you're not going to pay for it, people are going to go, never mind.
Okay.
I mean, we know that. The RAND has done work for 40 years that show that if people have to put their money on the table, they tend to make more careful decisions. And that's just human nature.
Okay,
Not
ma'am.
a lot, but just enough.
Do you want to respond to that, Ken or
would.
Sally? Okay.
Yes.
Ken Connor.
You've made a very good point that I think is a very important point, and that is that when we don't have skin in the game, we're less likely to be good stewards of the resources available to us. And so, for instance, I think one way that we can promote having skin in the game and the responsible consumption of medical resources is to allow young people, for instance, to have health savings accounts with high deductible insurance policies, and they've got skin in the game. Let the government subsidize or provide tax breaks to individuals who purchase health insurance, not just to businesses. The way the current system is set up is that we tend to overconsume the resources because we don't have any skin in the game. The employer is paying the bill, the government's subsidizing the employer, and there's no skin off our nose. And so if we want to promote good stewardship, then I think we ought to cause people to have skin in the game. And that would mean that they have a stake in their own health care decisions. If they do, they're less likely to overconsume resources than they otherwise would be.
This concludes round 2 of this Intelligence Squared U.S. debate. And remember, before the arguments began, we asked all of you to vote on this motion. We're going to ask you again after you hear the closing remarks. This is their last chance to try to change your mind. On to round 3, closing statements. Our motion is this: ration end-of-life care. And here to summarize her position against this motion, Sally Pipes, President and Chief Executive Officer of the Pacific Research Institute.
Thank you, John, and you know by now I am against the proposition that end-of-life care should be rationed. The Medicare trustees have projected that the program Medicare will be bankrupt by 2024 at a cost of $1 trillion, almost double the cost today. One of the ways to reduce the cost of our Medicare program is to deny end-of-life care. I believe it's morally wrong, but the position supported by my opponents. There are 50 million seniors in this country today on Medicare, and that number is going to expand exponentially as the baby boomers retire, and I am one of the baby boomers. Doctors are already feeling the financial squeeze. They're reimbursed by government at a rate 20% below what they get for treating private patients. It is no wonder that 52% of doctors surveyed say they're limiting the access of Medicare patients to their practices. Unless reformed, this could result actually in bureaucrats setting an age limit for one's life. We do not want a nice system in this country. It's not the American way, where a government body determines what is cost-effective rather than medically effective. America needs a healthcare system where doctors and patients make decisions about the best kind of care needed when their loved ones approach the end of their lives. Morally and ethically, this is the only way to proceed. I urge you to vote against rationing the end-of-life care. Thank you very much for listening.
Thank you, Sally Pipes. Our motion is ration end-of-life care, and here to summarize his position in support of the motion, Peter Singer. He is professor of bioethics in the University Center for Human Values at Princeton University.
We've actually reached a surprising amount of agreement in this debate because all sides agree that rationing occurs. Sally said there's always going to be rationing. Ken said we are all in agreement that rationing occurs. The question is, he went on to say, is who should ration? He says he favours rationing through markets rather than government. But you should read that article that he wrote that I mentioned before on the website about the problems of the elderly, because here's a quote from that article. For-profit nursing homes have on average 32% fewer nurses and 47% higher deficiencies than their non-profit counterparts. Let me just conclude by referring to the case that Sally began with, the sad case of her mother, and say that although that is a tragic case, obviously we cannot generalise from a sample of one. I've spent most of my life living under single-payer systems, either in Australia or in the United Kingdom. Or rather my wife, had 2 of our children in the United Kingdom and 1 of them in Australia. I think that the quality of care that we have received in Australia has been outstanding. I've obviously had medical care in this country. I don't think that it's better than it is in Australia. And I don't think that it's even more respectful of individual choice, because Australians can insure themselves in addition to Medicare.
Peter Singer, I'm sorry, your time is up.
Thank you.
Thank you very much. Our motion is ration end-of-life care, and here to summarize his position against the motion, Ken Connor. He is founder and chairman of the Center for a Just Society.
Let me say this. I think it's important to understand that rationing is not required in order for the healthcare system to remain solvent. That assumes the fallacy of only one alternative, that either we ration or we're going to go broke. That's not true. It's hard work to wrest resources from the hands of the special interests. We should not ration. We should not balance the budgets on the back of the sick and the dying. We can provide good health care for all people through and including the end of life. We need to ask good questions. We need to ask, are the procedures necessary? Are they clinically indicated? Is the cost reasonable? What we need is a rational approach to end-of-life health care, not the rationing of end-of-life health care. Thank you.
Thank you,
Vote
Ken
against
Connor.
the proposition.
Thank you. Our motion is ration end-of-life care, and here to summarize his position in support of the motion, Arthur Kellerman. He is the Paul O'Neill Alcoa Chair in Policy Analysis at the Rand Corporation.
Most Western democracies have healthcare systems that provide you with all the care you need, whether or not you can afford it. Our healthcare system has evolved to provide you with all the healthcare you can afford, whether or not you need it. Modern American medicine is a $2.8 trillion a year industry, and it is rapidly outgrowing our economy's capacity to support it. More high-tech care is not necessarily better care. Sometimes the basics, pain control, bedside attention, love, matter a lot more than the most sophisticated $100,000 medicines there are. That's why when terminally ill patients came into my ER, I did not immediately intubate, immediately start multiple IVs, immediately do anything I didn't absolutely have to do. Let me tell you what happened one night as an example. I brought a daughter who had cared for her mother for 10 years to the bedside. And I said, your mom has a severe pneumonia, she's septic. This is the 3rd time she's been in the hospital in the last 2 months. We can do everything we know to do, and she will almost certainly die, but she might pull through. And the best we can hope for is she'll be the way she was a week ago when she didn't recognize you and was in the nursing home. So my question to you is not, what do you want us to do? I know what you want us to do. You want us to make your mother the way she used to be. I can't do that. So I want to ask you, what would your mother want if she came back now and stood next to you and she said, Mama would say it's time. As you vote tonight, I ask you to consider, what kind of doctor do you want to take care of your mother, and what kind of doctor will you want to take care of you? And that should guide your vote.
Thank you, Art Kellerman. And that concludes our closing statements, and now it is time to find out which side you feel argued best. We're going to have the second vote now, so if you go to the keypads in your seat. After hearing everything, we want to know where you stand, whether you have been persuaded to one side or the other. If you agree with the motion, ration end-of-life care, the side argued by this team, push number 1. If you disagree with the motion, with this team, push number 2. And if you are or became undecided, push number 3. We now have the results in on your vote. Remember, we had you vote before you heard the arguments and once again after hearing the arguments, and the team who has changed your number the most, who has moved you to their side by the largest percentage, will be declared our winner. So here's how it breaks out. Before the debate, 43% were for the motion, 22% against, and 35% undecided. After the debate, 81% are for the motion. That's up 38%. 12% are against. That's down 10%. 7% are undecided. The side arguing for the motion carries the debate. Our congratulations to them. Thank you from me, John Donovan in Chicago, and Intelligence Squared US.